Our next moderator, who is having a very healthy discussion, is Dr. Amy Afable, and she is from the School of Public Health. And we have discussant Dr. Kutsia Banu. She is one of our transport scholars. She is the Associate Medical Director for Ambulatory Care Services at Brookdale Hospital and Medical Center. So I'm going to turn it over to Dr. Afable, and if you turn on your mic, you're good to go.
It's nice to see some people here, even after break. We still have good attendance, which is wonderful.
Would everybody who is outside please join us?
Okay, so I wanted to welcome my co-panelists today. I don't know who's going to present first. I guess it doesn't matter. So I'm going to welcome Tamir Bader, and I'm not going to give you too much information on his bio. You have it in the information booklet. But Tamir is a public health professional, currently serving at the program as program manager for the Diabetes Wellness Program at the Melting Pot Foundation and the Brownsville Community Culinary Center here in Brownsville, Brooklyn, New York. Please welcome Mr. Bader.
Thank you so much, everybody, and thank you so much for inviting the Brownsville Community Culinary Center to this wonderful event. Thank you to the Transport Committee. My name is Tamir. I'm the program manager for the Brownsville Community Culinary Center. We operate out of Brooklyn, New York, in Brownsville, on 69 Belmont Avenue. Many of you probably know the space. It's in the top picture right there. It's kind of a very unique space. So we're a diabetes wellness program, but we operate out of a culinary training kitchen. So all of our program services are right in the dining area. That space is also a cafe of this facility. It's unique, and I think it sort of is an asset of ours and why the community keeps coming back to our program. But so my name is Tamir again. I'm a program manager there. My background is in medicine. I graduated medical school from Avalon University, and much to my parents' disappointment, I didn't pursue the traditional route. I didn't go into residency and become a doctor. I went into the public health world. And because my passion was truly in health education, and that's how I ended up at the Diabetes Wellness Program in Brownsville. So just a little bit about Brownsville. Brownsville is a beautiful community, rich and vibrant with culture. However, it does face several socioeconomic issues. But most importantly, the issues that it's facing from a health standpoint is that it has the highest prevalence of type 2 diabetes than in any other city in New York. The highest prevalence of hypertension, the highest prevalence of obesity. In addition to that, the Brownsville community has the highest rates of avoidable hospitalizations in both pediatric and adults. The community suffers from a high poverty rate, heavy policing, which leads to incarceration and the disruption of the family home, and poor housing conditions. Our program, the Diabetes Wellness Program, was started at the height of the pandemic to essentially address these issues for the community, because our community advisory board at the time saw that the community, who already has so many factors stacked against them, in addition to a pandemic, would suffer greatly if they didn't have the additional support outside of a traditional clinical setting. And so our program is there to provide three major components, and that's resources, education, and access to social services. So one of the major components of our program is our weekly farm bag distribution, where participants can get free 26 weeks of farm bags, and these farm bags are filled with 6 to 7 produce items of different quantity, and they're enough according to current nutritional standards, to provide one individual with enough vegetables for a week. We also have on-site community health workers that screen our members for any unmet survival needs or clinical needs. And these services are provided in both English and Spanish to better reflect the community that we serve. We have a slew of educational services. We provide the Diabetes Self-Management Program, the National Diabetes Prevention Program. We have cooking demonstrations, cooking classes, fitness classes, and all this is operating outside of a dining room on 69 Belmont Avenue. It's really incredible and unique to see. One community partnership that we're really excited about, and Dr. Fabley told me not to mention her so much, but she's a sort of a steward of this program. We are serving pre-diabetic and type 2 diabetic patients above the age of 18, and what we're hoping to do is free up some resources for these individuals by providing them healthy, medically tailored meals for 12 weeks. And in addition to that, provide them with nutritional counseling services with a registered dietitian nutritionist and screening for any unmet survival needs by our community health workers. Some of the challenges that we as an organization are facing is that because of the high prevalence of diabetes within the community and the lack of resources, it leaves community-based organizations such as the Diabetes Wellness Program, it essentially, there's a great demand for services in the community. And so in order to meet those demands, we have to come up with unique solutions, such as operating within a dining space, hosting fitness classes within a dining space. I guess the end all would be that there is a high demand for services, but a lack of resources in the community. And I'd be happy to discuss that further with the panel. Thank you so much.
Thank you, Mr. Bader. And I forgot to mention, this panel will really be focused on how we've engaged the community thus far. So what are the real world models? What are we doing on the ground? And how does community-based participatory research really look, on the ground? So now we're going to transition to the Mexican Coalition. Jairo Guzman. And Jairo Guzman, I know through one of our doctoral students who started interning with his organization, and I was very pleasantly surprised to learn about the fascinating work that Jairo Guzman is doing. Jairo Guzman is the founder and president of Mexican Coalition for the Empowerment of Youth and Families, and co-founder of the Mexican Coalition of Youth and Families AC in Mexico. So I'm very happy to welcome Mr. Guzman, who unfortunately is feeling a little bit under the weather, so couldn't join us in person, but he is here via Zoom.
Thank you. Thank you for having me be part of your conference. Lots and lots of food to think about with regard to the different types of research, and certainly the context from which organizations like the Mexican Coalition can look to research and the different modalities to engage community-based organizations and more importantly, those we serve. I like to think that we serve as the bridge or as those who are beginning to work the foundation on which academia and others want to do research. But let me share a little bit about what our organization is. The Mexican Coalition it's an organization that is it's headquartered in the Bronx, but has offices in Brooklyn and in Manhattan as well. We have different programs. Preventive health is the major of the 4 programs that we have. Legal support, where we offer different things, education, and global support. When it comes to our preventive health program, we offer different programs with regard to what our preventive health is. The Ventanilla de Salud is a model that comes out of the Mexican government, and it's a rich and pretty much a secret jewel that I think the departments of health from across the country have not been fully aware of. But there's a Ventanilla de Salud at every Mexican consulate in the country. And there's about 50 consulates in the United States, and they gather large sums of information with regard to medical information, medical histories of Mexican nationals and others who come to the Ventanilla de Salud. And in New York, the Mexican Coalition is the organization that that coordinates that work of engaging Mexican nationals and other Latinx persons who come to the Mexican consulate or any of their entities to connect them to healthcare services. We do a lot of work around COVID prevention. We have an emergency food pantry. We do tons and tons of workshops on health-related topics. Amiga Confidente and Miradas Sin Sentidas are emotional support programs that we've created in partnership with academia. CRS, Comprando Rico y Sano, which is a program that we are using to help people understand the importance of healthy nutritional habits. NDPP, obviously, the National Diabetes Prevention Program is extremely important to the Mexican community because so many Mexicans have experience with diabetes, and we do nutritional counseling. Our legal support program offers legal clinics where we've had as few as 3 and as many as 26 legal immigration attorneys come in and offer free consultations to our community, know your rights sessions, translation of legal documents, particularly important during the immigration proceedings, and legal referrals. Our community often comes to us looking to be referred to trustworthy attorneys, and often after they've experienced or they've been victimized by fraudulent lawyers or others who portray themselves as knowing and being able to practice law. With regard to our educational program, we have we want to make sure that our community has as much knowledge as possible in order for them to be actually the ones who are helping others to understand how important knowing what raising health literacy, basically, it's extremely important to us. And these educational programs really help prepare our community for them to understand how to access different services. And in that, we offer classes so that persons are able to prepare for themselves for the naturalization interview. We want for them to be able to speak English. So we have English clip courses, among other things. But again, we want to make sure that education is central to all this piece. We realized really when at the beginning, when there was the conversation about wellness, and I don't remember which commissioner at the Department of Health mentioned this with regard to how wellness is the absence of illness, not the treatment of illness. And I think part of that for us is, or at least for me, has been very much based on education. We know that, education, employment, and migration status are the context on which we need to look at how well persons are doing. And we know that education is pivotal with regard to if a person knows what his or her rights are, she or he will be able to ask for certain services. If he or she has a better employment, then he or she will have a better access to higher quality housing and education. So there's a lot of stuff that's cyclical and interconnected, and a lot of it is based on education. When I mentioned our global support program, we do have an office in Mexico where we're working with persons down in Mexico, connecting them to services there and getting people documented in Mexico. We work very, very closely with Latin American consulates here. I mentioned the Ventanilla de Salud as being one program, and we try to embrace and reproduce that kind of programming with other consulates from Latin America to make sure that their nationals are being connected to the services that they need here in New York City. We host a number of interns and volunteers from local universities like Fordham, Columbia, NYU, but also from other universities, Ibero from Mexico City, Ibero from Puebla, ITESO from Guadalajara, and other countries. We've been participants and co-organizers of international conferences, primarily around immigration and how immigration impacts the wellness of many of our Latinx community members. We've opened up a high school in Tehuicingo, Puebla. And then we're also engaged in binational academic and cultural programs with some of the partner universities that I've already mentioned. But when it comes to research, one of the reasons or one of the things that comes to mind and hearing everything that's been discussed with regard to our involvement, and we have been involved in several research opportunities with NYU. We're currently involved in a nutrition-focused program research. at Columbia Medicine School of Medicine, Maryland, where actually our very first experience with community-based research was through the Urban Institute of Community, with the Urban Institute for Translational Research. We got a grant, part of the program gave $40,000. The university kept our academia partner kept 20, and we got 20 in order for us to engage in evaluating how Comprando Rico y Sano, this model that I mentioned before with regard to nutrition, was impacting our community. Was it the right model to use to inform our community members of what might be the best nutritional habits for them to continue to practice and what to change? We were engaged in another research program where we were talking about how crucial is the first 90 days of for babies and the intake of sweetness in their drinks. The first year, I'm sorry. We did a lot of work around research, around the impact COVID had. And we're currently engaged with the School of Social Work at Columbia as well with regard to what it means to have, or what impact the asylum seekers have on our community and vice versa, with regard to asylum seekers coming to New York City. With Fordham University, we've done some of the same thing, particularly around doing some research on COVID and the impact it's had on the Mexican community. We've done Fordham University and the Ibero University engaged on the research around the economic status of immigrants here and its impact. So we've been involved in this kind of research, and through this research, we've come away with some lessons that we've learned. Right, we've learned that often we seem to engage. We don't engage in the community. We don't engage the community often with a clear mind or a clear understanding of what exactly is it that we want to engage them for. As has been mentioned before, usually the topic is brought to the community, and then it's a work of trying to convince the community that this is the topic that they should be engaged and participate in. So it's inviting them to be part of that as opposed to engaging them and having them drive what it is that they want to be researching. But I think a lot of it stems with regard to not having a clear understanding of what community is, and based on that, how do we engage it, right? I mentioned with regard to research not being designed for us. A lot of it is, as I mentioned, coming in and telling folks, this is the topic we want to research, and we want for you to be part of that research. And there are things built into the investigation process that often keeps many community members away. And it's based on health literacy, is based on the fact that we have not done the work, and we being part of those that we engage with and at academia in helping to raise the educational levels for community to be involved in understanding exactly what an IRB process is, exactly what are some of the training that they must have in order for them to understand what research on human subjects implies, and confidentiality, and all of these wonderful things that are in place to keep people safe are still very foreign for our community, and therefore it's not, research is not really designed for us, and it needs to be made more accessible for us to be able to engage with them. And again, I feel, and when speaking with community members who participate in some of the research, often community-based research turns out to be more research done on the community as opposed to community-based research being the community deciding on what the research topic is. All right, so we become the laboratory mice in some of these investigations, as opposed to us being part of deciding what questions to ask, which surveys to develop, and how to roll them out. Now I do know that for some of the stuff, and this is particularly important for us with regard to what have we learned with some of the research that we've done, is that non-formally educated community members, and by that I mean, we have a great segment of our population that, due to economics, have not been fortunate to go through all the way through university and graduate through a college or university for them to really understand what research is all about. But they are and can be the best persons to engage in doing the surveys and in data collection, and not just engaging the community, but keeping the community engaged. And ultimately, they will be the ones who will be instrumental in making the changes that we want to see as results of investigations. When when it was mentioned that research can take 17 years to impact the community on which research wasn't done, that's a staggering length of time for a community member to be engaged in research, and then tell him or her, you'll see a positive impact on this 15 years down the road. Community members need to feel that it's not going to be that long, right? That their involvement means that this time is going to be cut, at very fast, so that we can begin to see our involvement pay out. I think, often it feels that it is a second thought for many of the players, the research, and for organizations, for the CBOs, and I have over 20 years of working with nonprofits. I've yet to work in a nonprofit where research is not a second thought, right? Often it's money that prevents organizations from engaging in research. Second is expertise. Not everybody knows how to do research. Not everybody has the time to do the research or learn the tools or develop the tools in order for us to do research, particularly for small organizations like the Mexican Coalition. Even if we didn't want research to be a second thought, we just don't have the capacity to do it and do it correctly. I think some of the things that make it very important for us to understand when we talk about language and accessing some of these tools is making sure that we understand, and academia understands, that the research that needs to be done is engaging community members that often do not speak English. So from the very beginning, that has to be considered. We found this to be a challenge when we were involved with mailmen in the Comprando Rico y Sano project, and folks who were going to participate were told that they needed to complete city, and city is in English. So they very quickly had to look to see, well, how do we get community members who are monolingual Spanish speaking to comply with the requirement of confidentiality and understanding how to work with human subjects in Spanish, getting instruments validated. It's I think validation is a major thing within the research community, and that becomes extremely important if we're going to validate instruments. To whose standards are we validating, and are these the standards that really connect to the community that you are wanting to engage? And I think some of these barriers are extremely important to look at and understand, and begin to feel that the community is engaged in many ways beyond them saying, yes, we'll be part of it, beyond them saying, we'll read some of these things and then walk away from that. So, these are important lessons learned for us as the Mexican Coalition, as a partner engaged in research with multiple universities. And again, I do think that we're building the bridge between academia, the school, houses of faith, and the community at large, for there to be good research done. But I do think that it is highly important for the community to feel that research, community-based research, does not turn out to be research done on them, but that they are really equal partners in deciding the whole process and what needs to be researched from the community's perspective, right? Where funding is funneled to the community first, and then to the universities, or somehow be more equitable, because it certainly isn't. So I'm hoping that these lessons learned give room for some food for thought as well. So thank you.
Well, thank you, Jairo, and thank you, Tamer. Does anyone have any burning questions, or should we begin the discussion? First, I just want to thank again the panelists for, for your commitment, right? So you both organizations obviously are addressing sort of major urban health challenges and adversities, a history of a disproportionate disease and mortality in Brownsville, for example, serving asylum seekers, not only their health needs, but their socio-emotional needs. So thank you for both of you. And thank you, Dr. Bassi, for really setting the tone for this conversation. I wanted you both to perhaps outline again or reiterate, building on the partnerships that you talked about today, your community academic partnerships. Can you just outline what current role do you play in that partnership, as well as what is the role that you foresee, or what is your perception of the role of your academic partner? So maybe we could start with Tamer.
Yes, absolutely. So essentially my role is to facilitate these collaborations with academic partners and clinic-based partners and other community-based organizations in the area. And so I'm the primary point of contact for these connections. The role that our academic partner facilitates for us specifically, and it's a very important role, for example, like in our Food as Medicine program, is evaluating the efficacy of the intervention for the community. Many of us who are employed on staff at the Diabetes Wellness Program, we come from varied backgrounds, but none from specific public health backgrounds or epidemiological backgrounds. So having an academic institution there as a partner is extremely helpful in helping us sort of publish results and provide efficacy for the interventions that we're trying to implement.
Thank you, Tamer. Jairo, do you want to just summarize your answer to those questions as well? Okay, so hopefully he'll get back. He's not feeling very well, but I wanted to build on that, the relationship you mentioned, Tamer, about you provide, the community-based organization sort of provides a service, the academic institution provides a sort of a research role, and I going back to what Jairo Guzman mentioned earlier, that also seems to be Oh, Jairo, yes. I wanted to just, can you hear us? Can you, okay, good. Okay, go ahead.
I was just going to say with regard to our role, one is we serve as a community advisor. So we do share our input with regard to what we think are does the topic or what needs to be investigated relate to us or not. The other is we do help revise the questions, review what questions are being asked and do they fit within the framework of what our community is. We identify members of the community to participate, and then we help keep them engaged or not engaged in the survey. And we're very clear about making sure that we identify agency members as being co-PIs as well. So we want to be able to make sure that we're not just rubber stamping a tool, or that we're just being asked to come in, take a seat and be part of it, so that the academia be able to say that they had a community partner. Thanks.
And also relating that to Dr. Abazi's model, the CRAB model, in terms of ensuring that funding to pilot projects are driven by the community. I want to sort of elaborate a little bit more on what your thoughts are with regard to those types of partnerships. It sounds like, there are sort of practical issues concerning community academic partnerships in community engaged research in terms of training, in terms of training and capacity building in sort of data collection, in understanding the human subjects, ethical review concerns, et cetera, and also training on sort of the research design, but also from the perspective of a higher level perspective, where I think, Jairo, you mentioned that it's important to, also emphasized by Dr. Abazi's the CRAB model, it's important to gauge them early. I want to ask both of you your thoughts on, whether you see it feasible or possible to move forward in a space where there is co-creation, right? Where there is co-leadership, as opposed to these sort of siloed areas that each partner belongs to. Again, sort of referencing earlier conversation about transcending our disciplines. Do you want to comment a little bit about that? What are the challenges to arriving at that, or are you already doing that? I know, we probably do have examples of some that are like systems that are facilitating that already, but I would like to have your perspective on, your thoughts on how we can get to that space or place.
Yes, absolutely. So I think it's very important that when we do partner with academic institutions or any institution really, whether that's clinical-based or another community-based organization, is to ensure that the visions and the goals are aligned. That's probably the most important asset in these collaborations from my perspective. And in addition to that, in addition to making sure that the visions are aligned, it's important that probably leads to the most fruitful and productive collaboration. But a challenge that comes along with that, with partnering with academic institutions or other institutions, is that sometimes priorities change. And for us, as a community-based organization, we only have one specific priority, and that's to address the chronic disease condition in Brownsville. However, when you're dealing with even funders or other institutions, their priorities, their goals, their missions may change. And so you'd have to adapt and be flexible and malleable to sort of like continue your mission and continue the partnership.
Thank you. Mr. Guzman? I don't know why he puts on mute. Okay, so he's not, we're not able to hear him. I know we have to wrap up, so I'm gonna have, are there any other questions before we have our discussant provide her commentary? Alicia.
Hi, yes. So in my work dealing with food insecurity, I learned about 69 Belmont because of the food rescue agape that's out of there.
Yes.
But they never mentioned about this program.
Of course.
So we have to stop with the secret.
Right.
We are hidden gems and secrets in our own community. So when I see the chaplain now, I'm going to say, why didn't you tell me we were in partnership? Because it's important to share this, because this needs to be duplicated in East Flatbush, Crown Heights, Ocean Hill. I could keep going. So you are a gift. How can we replicate this? I know funding is the first factor. I know I'm fighting for money now for us, but how do we duplicate this? Because this is amazing. I know the importance of having a kitchen, because like Camber Gardens has one. How can we now make it a moving kitchen? How to take what we in the Caribbean community cook and make it healthy, uncarb it. So that, I guess that's a continuous discussion, and has that been addressed or mentioned? Because I know this is not like a eureka idea that I just came up with.
Yes. So a big goal of ours through all of our interventions is to search for ways to make these things sustainable. We in developing our intervention, the most important aspect in developing any of our program components is assessing the needs of the community. So whether it's a diabetes wellness program in Brownsville or it's a diabetes wellness program in Crown Heights, that would be the first step in assuring that the program can be sustainable and continue long term. But yes, that is a focus of ours, and in replicating the model, we're hoping to address specific things, and those things are just assessing the feedback of the community and making sure that they're integrated into whatever intervention that we launch.
And I also want to add to that, Alicia, thank you for raising that. That's also, I think, an advantage of partnering with academics, because we can work together to sort of design the studies that we need to demonstrate impact, and then take it and elevate and amplify the findings, translate it to the this is a community group doing this already. We're just partnering with them to amplify what they're doing, and then we're helping them we give the technical expertise to be able to get the data out there, the evidence, but also translate it, work back with them and translate it to the community. They're the ones who are going to take it and, be our ambassadors. So I think that's a very important point, and I think that's where I think academia can help in that sense, because we could sort of talk to the policymakers, we could talk to the economists, we can talk to the healthcare payers, right? That's eventually who we want to be talking to, which is the topic of the next panel. Okay, go ahead, Jairo.
I was going to add, because I think one of the things with regard to the research piece is, one is for CBOs, at least our experience has been that it often, and for us, it becomes important because we need partners, academia, to partner with us to do program evaluation and be able to show whether programs work or don't work. I certainly agree that mission and vision is extremely important when choosing which projects to engage with academia. But we are emergency driven, and funding also drives those decisions. And I think that's one of the things that has to be in the decision making with regard to who do we partner with and what exactly gets investigated. And often that is a delicate topic that is kept off the table till the very end with regard to is funding available or not. And that implies building the capacity for agencies and community to be able to be engaged and be fruitful partners in that relationship. And that often is something that is left out. Again, if not left out completely, certainly is left at the very end of the conversation. Thanks.
Thank you, Jairo. And we'll have Dr. Banu wrap up with her discussion.
Hi, it works. I'm Kutsia. I'm a transport scholar and an internist. And I want to thank the panel for this amazing discussion, the audience, and the organizers of the symposium for having me. So my job is to recap the topic of panel number 2, which is how we are doing actually in the real world with community engagement. Is kind of a report card. So as we score ourselves, what I'm hearing is there's no one size fits all, and there is a spectrum of community engagement, and there are frameworks of this, obviously, and it can be less intense, as simple as letting the community choose the participants, to an intermediate level, then the very intensive level that Dr. Obasi was talking about, community-based participatory research, where the community is involved in every step. And where we start could depend on our resources, our expertise, and our experience. And it's important to start, and then the goal always being to build stronger research and more community participants. But I think what I'm hearing, that we also need to score ourselves on the spectrum. Some questions that I scribbled down when I was listening to the panel was that, have we provided enough time and resources to understanding our communities of interest? So like Jairo pointed out, sometimes we don't even understand how the community perceives themselves. So that contextualization needs to precede the research design. And we need to understand the needs, priorities, and norms is a way of centering the communities of their language, culture, and history. The second topic that was brought up is, have we taken the time to build trust so that community members are more likely to share their insights? So historically, and Dr. Obasi mentioned that, there is ample reason for mistrust due to past historical inequities and current inequities. And Jairo pointed out, a lot of the time community-based research is research done on communities. So there's enough reason for people to have mistrust. So to engage broadly with structured but open forums is important to build trust. And this can be like focus groups, storyboarding, but it's important to put out multiple ways, as we've had Tamir and Jairo say, and also use preferred ways by the community. So it could be text messages if needed, calls, emails. The next thought was brought up was, to what degree have we been able to create a representative group within the community? So there are micro communities and sub communities, and we have to let the community decide that. We can't say that everybody is homogeneous. So I thought that was an important point that was raised, that we should make sure that sub-communities, important sub-communities are included, so it doesn't become inherently inequitable. Next thought I felt was important was to ask ourselves, have we been able to create an equitable and empowering atmosphere that facilitates contribution for all community members? And both Tamir and Jairo brought this up. There's inherently a power differential between academic partners and community agencies. And the first thing is to acknowledge that, as we are acknowledging it here, and then try to mitigate it by capacity building to increase the confidence, knowledge, and skills so that the community partners can advocate for more equitable research relationships. There was a point brought up by Jairo, and I spoke to Dr. Abbasi about honoring the authorship of communities. That's one way of empowering the communities, and there was talk about validating instruments in their preferred language. These are all ways of creating equitable power balances. Dr. Abbasi brought up, have we created meaningful bidirectional flow? It was also brought up in the panel. The community gives us wisdom, fine-tuning, cuts down on the lag of translational research of 17 years, while academia can offer data, resources. Dr. Afable talked about connections. These are all valuable things. And there's a mutual respect where we understand what we can give each other. And there was a question by Dr. Salifu where he asked, why can't we be more transparent, or why can't we channel funds more directly? So these are all very important examples of bidirectional flow. Have we used community resources that was brought up by Dr. Abbasi and built capacity building? So TEMER is not only providing raw food material. There was a question about this. So we are talking about sustaining lessons and building capacity by changing or with the community creating new cooking skills. Finally, to what degree have we provided long-term commitment and sustainability? That's going to be discussed in the next panel. But trust leads to synergy, synergy leads to empowerment, and empowerment ultimately leads to sustained societal or structural transformations. Unsurprisingly, engagement with communities works best where we have vested ourselves the longest, where we have stayed the course, and where our faces are familiar and our voices are known. Thank you.
We've had a lot of food for thought today. Are there any other questions before this panel leaves? Okay, then I would like to thank Dr. Afable and to introduce Dr., as I was corrected today, Dr. Bhutan. Dr. Bhutan will come up, and she will be joined by Dr. Jumbo, and they will lead the panel on future directions and capacity building. And we have a couple of participants who will be online. One is Gabe Rodriguez, and he is from, as I attempt to read without my glasses, he is from our department research division here at Downstate. We also have Dr. Bean, who is with Health First. I don't know how she gets everywhere, but she's joining us today. And thank you so much, Dr. Bhutan. It's all yours.
Thank you very much, Dr. Straker. Hi, everyone. I'm Carla Bhutan Foster, and I'm really honored to be here. And so over the past couple of hours, we've been hearing about how do we more effectively engage community partners. And this next this next session really takes us to the next level. So now we're talking about, okay, no?
I made the biggest blunder I could have made. So, my colleague, Dr. Fraser, is a part of this panel. She is the CEO of Arthur Ashe Institute, and she is one of the directors of BHDC. So she feels she wants to introduce herself, but I want you to know she's in the audience and she is a part of the panel. This is called Doing It Without Your Glasses.
Oh, yeah, your slides. Okay, all right. Thank you. So I am really honored to have, to moderate this session with my colleague, Dr. Jumbo, and we're gonna focus on what's next. So our three speakers are Dr. Suzanne Bean, Executive Medical Director of Health First Clinical Partnerships, Mr. Gabe Rodriguez, Executive Director of Development for Research, and Dr. Marilyn Fraser, who is the Executive Officer of the Arthur Ashe Institute for Urban Health, Associate Professor in the Department of Medicine, and co-PI of the Brooklyn Health Disparities Center. So what I would like to do is to ask each of you to just give a brief presentation of your work, and then I'll ask some questions and we'll end it with Dr. Jumbo. So if we go in the order of the way in which I introduced, is that okay? We can start with Dr. Bean, then Mr. Rodriguez, and then Dr. Fraser? Would that work? Yep.
It will.
Thank you.
Well, thank you very much for allowing me to be part of this esteemed panel, to participate in this amazing morning. I don't think we realize as we sit here how much what we're discussing in April of this year is going to set the tone for many of us as we move forward in the year. The questions that we raise, that all of us are considering as we sit here: what is community? How is community engaged and operationalized? How have we engaged the community, and seeing some amazing examples of that? It made me think that, as we were talking about power, managed care, obviously Health First is a not-for-profit managed care organization sponsored by most of the voluntary hospitals in this region, including SUNY Downstate. We are a value-based model, which means that our sponsors and providers are aligned with us in creating an environment where people, our members, can thrive. But managed care in and of itself is always thought of as being the biggest, I don't know what you want to call us, biggest bank pocket in the room, I guess you could say. We have not only, lots and lots of funds that flow through organizations like ours, but we also have access to many, many kinds of stakeholders that are critical for improving long life and quality for the people that we're talking about. So our community is a little bit different from the managed care perspective, and from the Health First perspective, because of our nature, our sponsors have given us permission really to partner with them so that we are at the table often when these innovations, the research comes out. Dr. Duper, I remember when you started your program. There's more I need to do, obviously, to support you there. So we are at the table, and I think it is, I know last year I talked about humility. This year, I'm going to talk a little bit about Apollo 13, because as I've been listening to you, I have so many notes, I can't even put them together. But often we look at our communities and how they are trying to achieve the goals that we all want, long life with quality. And we're so discouraged. Oh, we're so discouraged. But we really shouldn't be. Our communities are making strides every single day. I'm amazed at the small community-based organizations that, like Apollo 13, take whatever's on the table and put it together to get from here to there. And so I guess I would say that Health First is aligned with being part of that community of pieces on the table that need to be aligned together so that there is balance of power, that we do eliminate mistrust, that we're mutual in how we build toward these lofty goals, and that community is really, in some senses, defined by where we need to be as a managed care company, aligned with sponsors, providers, and the many, a million, almost 2 million members that trust us. So that's my perspective this year. Respect. Respect for what our communities are doing on their own, even without us, and supporting that, and also, trying to shift that power balance that our last speakers talked about, so that our community members can feel that their ideas count. These young scholars that are part of transport can feel confident and comfortable that they're going to have ears that will listen to them when they produce evidence for us, and we as healthcare organizations being willing to respect that work and implement it. Thank you.
Okay. Thank you for Dr. Bean for reminding us of that little RESPCT. So now, Mr. Rodriguez, if you introduce yourself and the work that you're doing, and how does that help us to advance community engagement?
Hello, everybody, and I'm sorry I couldn't be there in person with you today. I'm also a little under the weather. I want to share a few things about my work here at Downstate and some of the work I've done with community engaged research in the past. This is a statistic I saw at a conference of the Association of Healthcare Philanthropy this year, and it just drives home the challenges of fundraising for healthcare in general, for health research. That 88% of private funding comes from wealthy patients who come through your ER, through your hospital, and that's a lot of money. And when you are an institution like Downstate, or you are a community-based organization, that is a population you don't have access to naturally coming through your doors. So this is what we're up against. It's an incredible challenge. And when I saw, actually the room gasped when we saw this slide presented this year, because it's so dramatic, and it just speaks to just already the inequality that occurs, just from the very beginning of someone trying to get care or trying to seek some help. So what do we do? I'm the executive director of development for research at SUNY Downstate. It's the first position of its kind here at the university. I actually sit in the research office, which is great. It gives me an opportunity to work with my colleagues across research to really understand what the needs are and what our strengths are, so we can maximize giving. I actually have been on both sides of the fundraising for different kinds of organizations. I've been on the small community-based side. I was at an organization called ACREA, which is now part of GMHC, but it was mostly known for its community-based research on HIV and aging. They still are the leading authority on adults over 50 with HIV and how they progress with the disease. And then I went to Mount Sinai, where I was the director of development for the Department of Medicine, which was also in charge of all COVID response, COVID research. And that became one tall task once I was in charge of all of that suddenly in 2020. So I've seen the perspective of being the small organization working with the large institutions and trying to get the funding, maximize the funding with limited staff, and also on the other side where we're trying to find community partners, or we're that institution that's working with the community partners, but also competing for the funding. So, in helping get the Center for Health Equity Research off the ground at Mount Sinai during the pandemic, I got to see a lot of that firsthand, where we were, we worked in the community, but we were also talking a lot about communities that I had some issues with how we were presenting that information. A lot of these hospitals, NYU, Mount Sinai, all of them have affiliates in Brooklyn, and you see them in the boroughs, and then I think use a lot of those statistics to kind of beef up their numbers a little bit, just between us. So it's something for all of you to think about as we try to get the resources that we deserve. So what are some of the obstacles for a lot of small organizations? That's the lack of fundraising capacity. That's across the board. as I said, the lack of wealthy patients. Research is a harder sell in general for the philanthropic world, and community-based research especially. It's esoteric. Donors want to see an impact on patient care. Just as the gentleman from the Mexican Coalition mentioned, 17 years is a long time to explain to someone that's going to be, where that's the time it takes to really show an impact. Donors definitely don't want to hear that. They want to see some results. They want to understand, and we know quality research takes time. And one of my pet peeves, having been on both sides, is that the larger, well-funded institutions are not based in our communities, but they're using our communities to establish themselves. And then they keep getting the funding that we also need. So what do we do about that? Some opportunities that have come up since 2020 is that COVID really drove home to everyone that research needs to be funded. And donors really did respond during that time. And then, as we all saw, as the pandemic took its toll, health equity really came to the forefront. I live in Queens, not too far from a public hospital that was on the national news because of what was happening there in the early days of the pandemic. And having, being at Mount Sinai at that time was such a contrast, doing my job there and then seeing what was going on in my backyard. It was it was a lot to handle, to think about. And then in the wake of the murder of George Floyd, a dramatic wave of funding that came through for social justice efforts has been made available, but are we taking advantage of it? And how long is this window really open? That's my biggest concern. But one thing that gives me hope is that our communities are the opportunity. Really take a look at, don't lose hope. Don't think that you're going to lose out on the money to the NYU's, Columbia's, and Mount Sinai's of the world, or whoever your competitors are, whoever's taking that funding in your community. But who's in your backyard? You're keeping their employees healthy, and they should know that. And you should work with them and show them what you're doing, and get their funding, get their help, get their connections. Also work with your civic organizations, your chambers of commerce, your local officials. A lot of government officials you'll go to them and you'll want government funding, and they're used to that, but I'm not sure that they're being maximized for their other connections in the philanthropic world. They can help make those introductions, and I think they're a valuable and underused resource in that area. So, and then finally, really giving your community members a platform to tell their stories. That's the most impact that you're going to have with donors once you get them in. So I am happy to take questions later, but that is my presentation today. Thank you.
Thank you very much, Mr. Rodriguez. And now we'll have Dr. Marilyn Frazier.
Good afternoon, everyone. It's a pleasure to be here. As was introduced, I'm the CEO of the Arthur Ashe Institute for Urban Health, and I have the pleasure of co-directing the Brooklyn Health Disparity Center. And just to talk a little bit about what we do at the Arthur Ashe Institute, I usually like to talk about Arthur Ashe a little bit because I think he was before his time. When he founded the Institute, he thought of 4 different pillars. One was community engagement, the need for us to be in the communities and be there to talk about health education, to promote health, to do research within the communities. And the Institute has done that within our barbershops, our beauty salons, faith-based organizations where we are in the community, doing community engagement, community-based participatory research where we let the community tell us what they need, and then we work with the community to develop and implement and also disseminate and analyze that research. And one of the things that Arthur Ashe was cognizant about was that we needed to be aware of the communities from which these people came, the countries from which people came. So he was very cognizant about immigrant health. And we are very aware of that and the importance that that plays into the work that we do within the beauty salons, barbershops, and within the community in general. A second pillar was to increase minority representation in the health professions. And we do that with our Health Science Academy, which is a pipeline program. And we started out with high school students that were interested in the health professions and making sure that they were able to do well when they got into college. And the reason why that program was started was because a lot of students of color do exceptionally well in high school, but when they get into the sciences in their first year, they're weeded out. And so we wanted to make sure that they had the capacity to engage in the sciences and do well, and to come back and do the work here within the community. And we recognized that we needed to start earlier in that pipeline. So we've started engaging middle school students as well. And then the third pillar of our work has been partnership. And Arthur, as I said, was ahead of his time, and he wanted us to make sure that we were having strategic partnerships. And he founded the institute here at SUNY Downstate Health Sciences University, an academic partner. A key partnership that has come out of the institute's work has been the Brooklyn Health Disparity Center. It's a unique community, academic, and a government partnership because it goes to the fourth tenet of Arthur Ashe was policy. And we need to make sure that we change policies, change the way that things are looked at. So the Brooklyn Health Disparity Center has done a lot in terms of community engagement, building capacity of community-based organizations to engage in research, working with faculty members so that we can have that engagement and that cohesion and that collective thinking that oftentimes is missed in research. And so we have done work throughout the gamut of that. And as we think of next steps and future directions, is thinking about building the capacity of community organizations, building the capacity of our community members to not only engage in research, but to do the work that they need to do. COVID has highlighted a lot of those things, a lot of those disparities that we knew were there, but it also highlighted the resiliency and the resourcefulness of our community-based members, our community members. And so how do we tap into that? How do we value our community members so that they can continue to do this work and their capacity will be built? So as we continue this, that we can ultimately improve health outcomes, improve health, not only for our community members, but also for our country as well, and the world as well. So today, I'm really thankful for being here. I thank you for being a part of this forum, and I look forward to our discussion.
Thank you very much, Dr. Fraser. Thank you so much to all of our panelists. So we've been hearing about sustainability. And Dr. Bean, I really like what you started us with, this concept of respect. And that is so fundamental to the conversation that we're having here, because with respect comes value. And we know what racism does is it devalues, and it creates this paradigm of who's superior and who's inferior. And then that sets the stage for a whole host of policies that deliberately and intentionally removes value. So it saps. I think it was Dr. Kamara Jones. She described racism as structured policies and programs that removes value, creates this inferiority, and it saps wealth from the community. So now respect is recognizing value and putting wealth back into the community. So this leads me to think about funding. And Dr. Salafu talked about it, the way that the funding is allocated, just like, here's a dime, make it work. But taking the Apollo 13 analogy, how do we create bigger pieces to put together? So how do we change the way, the way the community honestly is perceived and valued? How do we create a greater influx of money, big money, into the community to do the capacity building that Dr. Fraser talked about?
I'm going to start. I do think that, value in most of our communities is sort of a multifaceted thing. Some of it's generational. Of course, it's institutions that value as well. But I think the real value is the ability to express and implement ideas that do come directly from the experience of those who are trying to live a long life with quality. And I think that that's part of what I mean by respect is that one of my crusades is just respect the fact that people want to live long with quality. You know, our healthcare delivery system has sort of missed that. So what I'm seeing now is consolidation of evidence, consolidation of concepts, but they're still not, as you're saying, coming together to build equity. And I think that, you know, we do have to think, work through companies like mine, organizations like SUNY Downstate, and to find the value that we can bring to the table. I mean, Health First is not giving out the grants, let's say, that Aetna is, but we will give technical assistance. We will, you know, bring to the table a meeting place, et cetera. So I just want to, I know that that's not really what we want to hear because we're trying to do this research and get it done. But I'm feeling like if we're all at the table, there's a greater chance that we can achieve what Gabe was talking about. Gabe, I don't know. Do you agree?
I do. It's a really tough question. It's a tough issue. I think that there's a really great resource. I think everyone should read this book. It's called Decolonizing Wealth by Edgar Villanueva. It's probably the first, and it's likely the authority on the issue, but he talks a lot about, you know, just in the philanthropic world, at least, getting these institutions with just enormous endowments, just pots of money just sitting there and getting them to actually release it and realize it's sitting on these and you know, allocating the 5% that they're required to legally every year is just continuing to perpetuate colonization. So it's, you know, it's going to take a lot to really break the habits, the patterns, the comfort that the establishment has with these things. But you know, everyone needs to come together to really make some changes.
I think the only thing I'll add is that sometimes, not sometimes, but I think power is a hard thing to give up. And I think we know that with power dynamics, that's difficult. And I agree with everyone being at the table and changing the conversation, changing the ways that things are being done. But I'm hopeful. I mean, recently NIH released the Compass grants, and those recognize the importance of the community-based organization being the one that was the funded entity, right, and the lead entity, and then you had to partner with academic institutions. So those changes are happening, so I'm hopeful that those can continue.
Thank you. And Dr. Fraser, you also talked about the next generation. So advancing community engagement also means that we prepare a future generation of equity-focused practitioners, health education, public health, and clinicians. So what should we look for in the next generation of public health clinician advocates? And we have some of our scholars here. So
yeah, I'm always excited about the work that we do. I'm always excited to see younger people that that are excited about health and excited about healthcare. And I think we need to have those conversations earlier on, even in their curriculum, from the time that they're in high school, middle school, even elementary school, thinking about the landscape so that they can understand the communities that they're participating in, and that is something that we hope that those that are more advanced will mentor the ones that are coming up. So I think mentorship mentoring is an important aspect of that people can see others that look like them and that they're able to understand that this is something that's obtainable and something that's achievable. And I think that we can all do that as we move on and make sure that we are increasing that, because the statistics, as you know, in terms of like people of color in the health professions, it's really something that's really discouraging. But again, I'm hopeful thinking about our young people and the ones that are excited and want to change the world, and that's something that we need to encourage as much as we can.
Thank you. And so this is a question for all of our panelists. um, who is missing? Who's missing from the table? So we have, we heard about community advocates focusing on food insecurity. We focus on chronic disease management as well as urban development. But who's missing? Who are the other key participants, key informants, stakeholders that are missing from the table that we need to engage to really advance the needle on community engagement and address disparities and inequities?
I'll take a first try. You know, I wrote down, and you all, my colleagues were coming at us so quickly, I couldn't remember everyone who said things, but someone spoke about building blocks, and I was thinking about bridges, right? I mean, I think that if we could bridge ourselves one to another as organizations, as not-for-profit, as small, large, medium, etc., with equal balance around the table, I do think that innovation will rise to the top. So the relationships that we all have together, maybe they need to evolve and be redefined. I know if anyone has a almost 30-year-old or early 30-year-old person in their orbit or their family, they're schooling us all the time. You know, they are processing what they're seeing. And a lot of them are in this room, you know, this virtual room today. So I think there's some listening that some of us have to do to hear things differently, you know, and I do think that we are not even doing a great job of connecting those who are already, you know, moving in the direction. That's one of my aims, is more connection, more relationship across those who are there, communities, community organizations, young people, older people, you know, et cetera, et cetera.
And to
Health
Dr.
organizations, yeah.
And to your point, you know, the old guard philanthropy world is probably a lost cause at this point, but the next generation, as you point out, that's schooling us, they care about these issues. Not that their parents don't, but they're going to inherit this wealth, and they're not at the table right now. No one's inviting them, partially because the money's not in their control yet, but you need to get to them somehow while all of this is ruminating, so they can be our allies and be there at the table with us and hear these stories and meet the community, because they're so detached from the community that, and they may want to help, they just don't know where to begin. And so they go to the usual suspects with the funding because they trust that their money will be used wisely and that can actually be put to use better elsewhere.
Yeah, and I think I do agree that we need to deepen those relationships as well. And I think also the policymakers need to be there, because we can do all of this work if we don't change the policies, if we don't dismantle systems, then we are just doing the work over and over again and hearing ourselves talk and have forums and so forth. So I think having them at the table and listening, as Dr. Bean said, you know, really listening to those voices that are already at the table.
Thank you very much to all of our panelists. So I would like to invite Dr. Jumbo to summarize key points, take-home points.
Sure. Thank you so much, Dr. Preston Brewster. This had been a wonderful presentation, and as you can see, I've been taking a lot of notes. All right, so this particular panel focused on future directions and capacity building. And one of the things that I heard that was discussed was the what, right? What the community need, and also how do we engage them in the research that we are, you know, contributing to the community. And the most important thing is a value base. We need to, you know, see that they are more valued in the research that we do. And also, the good thing that I heard from Gabe was that there's a lot of money out there. Yes, everyone heard that? You're my witness? There's a lot of money. You just know how, you know, to get access to those resources to do the work, which we're all kind of responsible to do. Also, the next thing that I heard was, recognizing and utilizing the framework of Apollo 13 to take whatever that is on the table and run with it. And most especially, do not be discouraged. Continue to do the work, continue to seek the funding, continue to talk to policymakers. And the need to enhance balance, meaning the power that we share, and also to enable us to achieve actionable goals. And the most important thing that was also mentioned also by Dr. Bustin Foster on the table was the respect. We need to respect our community. We need to integrate their ideas, not just bringing them in, right, but also integrate their ideas in the things and the research that we do. So the need for fundraising to support our community research, to acknowledge that there is also competition. So remember that you're not the only one that is looking for the money. That is very competitive. So when you are looking for the fund, just acknowledge that. And that research, we acknowledge that research is a difficult undertaking. However, we should continue in that path because you cannot give up. And to also to recognize that quality of research takes time. It does not immediately translate into the clinical arena. However, we should continue to understand that equally cannot be kind of eliminated when we talk about research and as it relates to our community. And that we should also engage the civic organizations such as governmental entity, because they will be responsible in putting together the policies that we need to make things work. We also need to engage the community, deeply in the research that we do. From the beginning of the research, not just starting from what you have, but also engaging them from the beginning to allow them, to vocalize their needs. Because you need to, that one of the things that, I thought when it comes to problem solving is to understand the cause root. So how do you understand the cause root without involving the community? And also the importance of increasing the research program in our community. So not just, one way out and one way in, but increasing, that research program and the importance of partnership across the community, including the academic center and otherwise. Establishing functional and inclusive policies. So there's one thing to have a policy, but another thing to make it more inclusive for everyone. Building the capacity in our community, building a capacity for our community member to involve them in all aspects, not just half-baked, but in all aspects of, of research activity to improve our health. And also to understand that value, as seen by our community, is multifaceted, consolidating all the evidence, and also the concept are insufficient. We need to find, different ways to really engage them for our research to be adopted. And to expand our horizon in seeking funds, like I mentioned before, which can never be understood. That is always a problem. I've heard someone ask about it, and also Dr. Soderfoot also talked about fund this morning. So fund everywhere that you go is very important. And also for us to realize the power of dynamic, leveraging the power of engagement, and which we're all here today, to hear about community engagement. Okay. Now, also talked about building the next generation. How do we engage the next generation to be an advocate? Engaging them early in the conversation so that they will understand the problem that we have. Also, the importance of integrating Building engagement in the curriculum to start it early, okay? And also the importance of mentorship, which I can attest to, by the way, as a transport scholar, that it is inevitable, to help to help the generational growth. And lastly, who is missing? Who is missing on the table from everything that we talked about today? Okay, so we have to understand the importance of building blocks and the bridges that will help to emerge all stakeholders, right? Recognizing equal balance again, and the need to do things differently. Also creating connections, right, creating relationship, and so on, and including the next generation early, start early, for them to learn early, for them to learn the trade, because you need to learn the trade in order for you to be good at what you do. Thank you.
Well, thank you to all three of our panelists. Thank you, Dr. Jumbo, for giving us a really great summary of what was discussed. I'm not sure if I have time for questions.
Yes, you do.
Yes, I do. Okay. I was looking at the boss right here, Dr. Salafu, and I was like, should I ask? Okay, I'm good. He said yes, so.
Thank you so much for a wonderful panel discussion. I had a question for Gabe Rodriguez and also maybe Dr. Bean. Over the last 10 years, we've seen all the big institutions like Mount Sinai, Columbia, Northwell, they've just taken over practices in all these communities. And the reason why they've reached out to all these communities is because of patients, right? They need patients. And I'm just wondering, hospitals like ours are struggling while other hospitals are taking over patient practices. Why can't some of the funding which you talked about, like Mount Sinai gets, take over projects in this community which will build capacity and get them patients too, because the projects are in the community?
Yeah, it's one of my pet peeves, and I believe there needs to be a lot of education happening with the philanthropic community. So, it's going to take a lot of work, but it's also, those institutions that are coming in and working with the smaller community-based organizations or smaller health institution hospitals, those are conversations that need to be had with them as well. Say, look, you're coming in here, you're using our population. Where is what we deserve a piece of this? Can you help us get this? Fundraising is so competitive, and they're not going to give up their donors. But there has, if they truly care about the community, they're going to care about the institutions in that community. And I would call them out on it. I don't think anything's going to change until they start getting called out on it. And that funders also start to understand that they need to be part of this solution as well.
And I'm going to add to that, Gabe, that we as health institutions and organizations always underestimate the wisdom, intelligence, and knowledge of our consumers, our patients, our members, our clients. So, just because I take over Gabe's practice doesn't mean that my patients are going to go to Gabe. And so people are not widgets. And I think there's a lot of power in realizing that, if we give that power back to the community. So the community, 70% of our members seek care with small providers in the community. And we do have New York State that's about to release an 1115 waiver. Let's be ready. Let's have structure to our community-based organizations and our community providers. So we do have to reach I love the way you summarize the bridges and the deepen the relationships. People are not widgets, but what happens when they disconnect is that they lose, right? The patient loses because they're not accessing evidence-based medicine. So, a lot of what we're thinking about right now is with organizations like Arthur Ashe, and SUNY Downstate and others, is how can we support in that, gray space so that people aren't lost because of lack of respect, devaluing, et cetera.
Hi, thank you for a wonderful panel discussion. My question is similar to my colleague, and it's directed towards Gabe Rodriguez and open to the rest of the panel as well. So I like the fact that you mentioned how bigger, more famous schools like Columbia and Hopkins often takes funding for health disparities research, but doesn't always apply their findings to the communities most impacted by these disparities. And so since this type of research is often done as a community, how do you think we can go about holding these institutions accountable in making sure that they are actually serving underrepresented communities?
Oh, gosh, how do you hold Johns Hopkins accountable for their research? I think you need to take a look at who are their big funders. Like Michael Bloomberg is probably the biggest funder of Hopkins. He's an alum from there. He's probably poured hundreds of millions of dollars into it. He was the mayor of New York City. How much has he given? I'm sure he's given a lot. I know he's given a lot in New York City, but take a look at who the biggest funders are and see what inroads you can make in with those folks. They care about they claim to care about our communities. Can you make those relations with program officers, with elected officials, with connections at these places where you can start to educate them? It's really going to be about educating and convincing about the importance of working with everybody and not just giving those funds up there, because really they care about making sure that everyone is being reached. But I think there's just they're just very comfortable giving these funds to large organizations because they feel it's going to be stewarded well. You also can't underestimate the fact that, Mount Sinai, when I left, had 115 development professionals working for it. 40 of those were frontline gift officers. That's all they did was ask for money. That's a lot that you're working. That's a competitive advantage that most organizations do not have. And that's what you're dealing with when you have one grant writer and a development director. It's tough, but it takes a lot of work, and it's not an easy answer. So hopefully I answered some part of your question with that.
If I could just build on what Gabe is saying, what I'm taking from Gabe is you said it yourself. You've been in, you've been out, right? And we have to build both ways. So I was sitting here thinking about the future and capacity, et cetera, and thinking about all of the, I'm an internist, right? As some of my colleagues here are, all of the evidence that leads to longer life with quality, right? And of course, we want our physicians and providers know, right? They know what the evidence is. They don't see how they can provide it. So we have to do that piece. I'm a healthcare organization. But, I received JAMA, Annals, Diabetes Care, all of these journals in my home. My mother lives in my building. She reads every single one. Sometimes New England Journal, she points out articles to me. And, we don't capitalize on the literacy that our communities have. It may not be the literacy that Johns Hopkins has, but they can understand the research that all of you are doing if we give it to them, So I'm just thinking, what if we, respect our communities enough to say, we're going to have a session today to tell you about the most current treatments for hypertension. Boom. And just lay it out there. I mean, drug companies do it on TV all the time. So, I think that part of this, to meet Gabe in the middle, is to have consumers that are demanding from Mount Sinai or SUNY or whoever it is, give me this hypertension medication, So I do think we could do that. I think we could do that.
And the last point on my last slide was that, the community is the opportunity that all of us have, and focusing on them, letting them tell their story. The more you can put your advocates, the people you've helped, the people who are grateful, I talk about grateful, wealthy patients. You have grateful clients, patients in your programs who are going to be your best. They're going to be able to reach those funders better than anybody else. They're the authentic voice. Yes, they want to hear from the experts, but they also want to hear from the community. And I think using them as best as you can in a respectful way is very important.
Yeah, I challenge you, transport scholars. get out there and talk to the community about your research. We now, Dr. Fraser was with us earlier today. When Health First talks to its providers, we invite their staff, we invite community-based organizations, we invite home health organizations to hear the same evidence-based practices that we're giving to our, highly recognized physicians. So I feel like, I love that, Gabe. The community is our, how did you say it? Our opportunity.
Yes.
Hi. So I work at the Department of Health, and I'm an evaluator for community-based COVID and briefly monkeypox programming. And one of the challenges for my team is thinking about what are the indicators that we can demonstrate to our agency leadership and to city leadership, the folks who are responsible for us continuing to get funded or looking for those opportunities to continue to get funded. So we can't draw a direct connection between the education, the connection to treatment, the connection to vaccination, and the health outcomes that are most important to these folks who are only going to be there for a little while, even though the impact that the community-based organizations are making are long-term. We use them because they're trusted in the communities. And so thinking about what you were talking about, Gabe, and then also for the other presenters, how do you think about the short-term indicators that can help projects with the potential for long-term impact sustain funding? So what are those like shiny things that folks will pay attention to so that the continued work can be sustained?
So you said it perfectly, shiny things. Fundraising is about storytelling. You need to find the story. You need to take that data, take whatever you are seeing, and then you need to humanize it. You need to tell the story of the person that impacted. A donor, you will have your technical organizations like the Gates Foundation and those that really want a really kind of like an NIH style proposal. But most funders don't know the science, don't know the nitty gritty. They want to hear how that work translates into as Dr. Bean said, a long fruitful life. And you need to find those stories, find those people, and just tell it, and in a compelling way, write it, have them, prep your clients to speak with donors in a way that is authentic and inspiring. It's all about inspiring people to support your work. No matter what your outcomes are, you're doing something good. Find those things, find those nuggets, and even though it's a long-term project, long-term impact, you can start sharing some things right away.
Thank you, Gabe. We have one more question.
Thank you.
And
Good day, everybody, and greetings. My question is, there are a group of people who are forgotten, like the old people, the elderly people, the homebound, and the bedridden. And we talk about community-based, but I sat here and nothing has not been mentioned about them. Another thing is, sorry, my hands are shaking. It's community-based technology. Before I came to this class, I tried 6 times to do my own registration. I did not get through. I had to beg my grandchildren. Oh, Granny, I forgot. And yesterday they came and do it. We are the forgotten one. And in all this conversation, nothing has mentioned about the old, the elderly, the homebound, and the bedridden. And the whole world, and I think the country is too conscious about age. So can somebody address
thank you.
that?
No, thank you so much for mentioning that. I know that a lot of the work that has been done and some of the work in going out to senior centers and so on is to answer that, because as you said, people, as you age, sometimes you're often forgotten.
Wow.
And when we think about it, our populations are older, and we have more people that a larger percentage of our populations that are older. So it is so important that we remember that. And also when you talk about those that are older and as you age, the caregivers are often forgotten as well. And so it's important that community-based organizations focus on that. It is important that academia, that when we are doing research, that we are focusing on that population to include that population, so things are designed and developed for populations such as those, and also that you're part of the implementation and all of that. Technology is something that is so major. We are moving so fast that there are times that we were brought into this Zoom age because of COVID. And when we are doing things with our beauty salons and our stylists and our barbers, we've had to go through, this is how you get onto Zoom. These are the things, these are the steps, because it's difficult. Right, and so I really thank you and applaud you for bringing that to the table, because it is something that we really need to pay attention to. We also need to pay attention to populations that have disabilities, and making sure that we are inclusive when we think about the populations, that we're not just thinking about maybe race, ethnicity, gender. There's so many sub-layers within there. So I applaud you and I thank you for bringing that to the table. And there are things are being done here at Downstate. Research is being done and work is being done to look at populations that are aging, older populations as well.
I just want to bring to your attention that there will be topics associated with that or including that in the next session. So do understand that we have not forgotten it, and there are projects going on in the School of Public Health. In fact, I'm working with Dr. Fable on issues that have to do with aging. I myself was a caregiver, so I do understand this issue. Okay?
I also
All right.
wanted to add to that, and this is why it's important that Dr. Boston Foster mentioned and asked that question, who is missing on the table? And that's an example of who is missing on the table.